Hello, everybody. Thank you for tuning in. Today we are starting our 12 lead series titled All About 12 Leads. This is part one. It is going to be geared towards everybody. So EMR, EMT Basic, Advanced EMT, Paramedic. This is for everybody. For some, it might be some review. For others, this might be information you've heard for the first time, or maybe it was something you heard, but it was a while ago. It'll be good to go over it. Today, I want to cover general information, like I said, so I want to hit some anatomy and physiology. I'm a strong believer that just the more familiar we are with the tiny parts of our body and how they're all fit together, the easier we're going to make life for us as we're trying to diagnose and treat illnesses. So go over some anatomy. I want to do the pathway of blood, different chambers of the heart, as well as our electrical conduction system, as well as I want to review when we're doing 12 leads, why are we doing so many of them? Why is it important during all of these different scenarios, even if it doesn't seem like maybe it's a cardiac thing? Why are we doing them? As well as what are we seeing when we are doing a 12 lead? What are all these boxes? We have small boxes, we got big boxes. What are these lines measuring? What do they mean? I want to go over some of that. So hopefully after today, it'll be a great refresher or just a great intro to the 12 lead skill. So with that all being said, let's get into it. I want to start by going over the pathway of blood here and reviewing the cardiac chambers. So, sorry, I'm having some issues with my iPad here. No, stop. Okay. So let's start with our chambers here. So the heart is divided into 4 different chambers, a right side and a left side that is separated by a septal wall. On the right side, up top, we have our right atrium. Right atrium is responsible for receiving deoxygenated blood from the body. So this individual over here, they're doing some sort of activity, perhaps jogging, going for a walk. They're expending oxygen and they need more. And so they are going to do that by supplying the right atrium through the vena cava, the largest vein in the body, and that's going to descend into the right atrium. From there, that blood is descending further to our right ventricle, where it ends up going to this kind of blue circle here. That is annotating our pulmonary artery. And so via our pulmonary arteries, we're going to have deoxygenated blood that enters the lungs. Once in the lungs, gas exchange can take place, and oxygenated blood takes the place of that deoxygenated blood, where it is then sent back to the heart via the pulmonary veins. And from there, it is going to enter the left atrium. Once it's in the left atrium, it is going to descend further into our left ventricle. Now, all chambers of the heart are equally important. Without them, if you just take one away, we would die. So very important, but I will say this left ventricle specifically is kind of the ringleader here, has the most significant muscular strain on it. It's going to supply blood to the entire body, so it has to have a lot of force. We'll kind of go back to that a little bit later when we talk about the electrical conduction system and different waves we might see on a 12 lead. So from there, via the aorta, it is going to deliver blood to the body, where then this cycle can repeat itself over and over and over all the time, which is pretty sweet. It just does it on its own. So now that we've reviewed the different chambers of the heart as well as general pathway of blood. I want to get into some more anatomy and go over the electrical conduction system. So your heart is very cool in the fact that it operates off of electricity. Um, it, it's pretty incredible how this all breaks down. So we have multiple sites in our heart that are kind of chief electrical conduction sites where they're responsible for conducting electricity. And the primary spot that is responsible for electrical conduction is this right here that has the 1 next to it, and that is our sinoatrial node. Sorry, I spelled that wrong. You might hear that referred to as just your SA node. That's completely fine. We have other sites as well. Number 2 here, that is going to be our atrioventricular node. You might hear that referred to as our AV node. Annotated by the number 3, we have these kind of spindly descending lines, and those are going to be our bundle branches. And we will go over these further detail after they are identified. And annotated by the number 4, we have our Purkinje fibers. Okay, so what does all that mean? So let's start with our sinoatrial node here. Our SA node is responsible for primary electrical conduction of the whole heart. So when the heart beats, it is because a conduction was initiated and sent through the SA node. So I'm going to choose a yellow highlighter here. Let's see if we can kind of see what this looks like here. So we got our SA node here, and we are initiating an electrical impulse. From there, that electrical impulse is going to go to the other hubs, where it will further be disseminated into the rest of the cardiac muscle tissue so that it can conduct that electricity and then create a muscular contraction, allowing the heart to do what it does best, which is pump blood. That's what it's designed to do. So we got the electrical stimulus starting in our SA node, and it's going to work its way to our AV node, where then it is going to descend to the apex of the heart, which is just the most inferior portion. It's kind of our point here. And it's going to travel down our bundle branches, where then via the Purkinje fibers, it will further spread around the bases and kind of circumnavigate the curvature of the heart. So just to go over that one more time here, we got an electrical stimulus that is starting in our SA node. It is then going to kind of laterally travel, or I guess, well, on here it's laterally, but it's going to travel inward towards the AV node, descend down via the bundle branches, and then outward and around, circumnavigating the cardiac muscle tissue via the Purkinje fibers. Now, that's great. That's wonderful. It's pretty cut and dry. It's basically just the path of electricity that is followed in the heart. But that is when things are working correctly. I want to go over some things that might not go correctly. So our SA node, it generates an electrical impulse at a specific rate, as do these other sites as well, but they're not the same. And so the SA node is going to generate an impulse at 60 to 100 beats per minute. That might sound familiar. Well, that is our quote-unquote normal heart rate range for vital signs. So when we're looking at a heart rate that is outside of that window, that clues me in as a provider to there might be something electrically wrong with this patient. That electrical impulse that is controlling the heart might not be originating from the SA node. We might have a conduction issue, which could indicate a potential perfusion issue as well. So let's go into it further, okay? These other sites, they are also able to conduct electricity on their own and initiate cardiac impulses. So let's say, I'm going to use an analogy here. Let's say we got our SA node, our AV node, our bundle branches, and our Purkinje fibers. Let's say they are avid sports fans. They're avid football fans, and they, we'll say our SA node, it's a big game for their team on Sunday night, and they're super excited. It's, conference finals, and they're very pumped, and they stay up really late. They might overindulge a little bit, and because they did that, they don't show up to work on Monday. And so who is going to do their job? Who's going to conduct electricity? Who's going to initiate electrical impulses for the cardiac muscle cells? It's very important. We all depend on it to live. So there is a fail-safe in place. So if the SA node doesn't show up to work, our number 2 in command, our AV node, or atrioventricular node, is going to show up, and they're going to step up and they're going to run things, but they don't do the job as much, so they're not quite as good at it. And so what I mean by that is the rate at which the AV node is going to initiate electrical impulses is slower, and it's different than the SA node. It is capable of generating impulses at a rate of 40 to 60 beats per minute. That same concept applies to our bundle branches and our Purkinje. Imagine the SA node and the AV node, they were both huge fans. Maybe their teams were playing each other or whatever, and they watched the game together, and neither of them showed up for work the next day. They're just totally spent. Well, who's next in line? Our bundle branches. They are capable of providing electrical conduction as well and initiating electrical conduction, but it is even slower. And the Purkinje, they are equally capable as our bundle branches, 20 to 40 rates per minute, 40 beats per minute. So again, why is this important? This is important and pertinent to me because if I see a patient with a heart rate of 30, there is a strong possibility that their electrical stimuluses are not being initiated and conducted by our SA node or our AV node, and it's probably in one of our bundle branches, which is not normal, and that might mean we have some cardiac issues. Now, that does not mean that if you have a heart rate that is, 120, okay, my heart rate's above 100, I'm outside of that normal range. Is it still initiating from the SA node? Yes. The SA node is capable of producing electrical impulses at slower and faster rates. That's just a part of what makes the heart so efficient. So you're exercising, you go for a run, you go lift weights or whatever you do, your heart rate is probably going to be higher to meet the demands of your muscles. And as a result, the SA node knows to meet that demand, and it will increase its beats per minute. The others are not quite so efficient at that. Likewise, the SA node can even go slower. Say you run on that patient who's a marathon runner. They run many miles a week. There's a good chance that their resting heart rate is below 60, and that can still definitely be originated from the SA node. we'll go over some more electrical stuff when we go over what the different waves are looking like, but as a general theme, this is what the electrical pathway looks like in the heart. Okay. Moving on, I want to go over the lead placement. I know many of you are familiar with this, and that's great, but I just want to review it. It's something that is always beneficial to review. You know, I have this picture of this really muscular, lean individual, so it's pretty easy to see all of our landmarks. Might not be quite so easy with, our average patient though. So our limb leads, we got our right arm, left arm, right leg, left leg. Those have to go, simply put, on our limbs. So I'm going to say where the shoulder and the chest separate, at least on that side of the shoulder. I don't want to see them, up on your traps or collarbone or anything like that. It has to be at least on the extremity. So on our shoulders, at least. You can put them further down the limb if you'd like, but that's the closest I want to see it to the body, is on the shoulder. And not just me. I mean, that's what studies are showing that are the most effective. Moving down to our legs, the highest up that is acceptable to see those leads would be where our hips and our leg meets, just below the crest of our hip there. Now you can obviously put them on the leg itself, but that's the highest. I'm going to see it towards the torso. Moving on, we got our V leads. V1 is going to be that fourth intercostal space just right of our sternum. V2, fourth intercostal space just left of that sternal space. I want you to skip V3 for now, and I want you to proceed to V4. V4 is going to be in the fifth intercostal space, kind of the mid-clavicular line, basically below the left nipple. If you're performing this on someone with a lot of breast tissue, again, be professional, use the back of a gloved hand and be as respectful as possible. Cover their modesty up, but you might need to lift that breast tissue up to get directly below the nipple in the fifth intercostal space. We're then going to backtrack to our V3, and you're just going to split the difference between V2 and V4 and put it smack dab in the middle. All right, that would leave us with V5. That is going to be level with V4 at the left anterior axillary line. Again, just to remind you, our axillary line is going to be the plane that would separate the body from the anterior portion and the posterior portion. So when we say anterior axillary, we're going to say, all right, we're going to cut that body in half, anterior, posteriorly, and we're going to be on the anterior portion of that line. And so, as you can see in the image here, we got V5 along that line. Last but not least, we got V6. It's going to be level with V5 at the mid-axillary line, basically midway point of the armpit is what we're looking at. Now, if anyone has any questions with 12 lead placement, hit me up, text me, email me, come into the office, or if I'm at your engine house, I'm happy to talk about this stuff with you. There are some other variations that you might have seen or heard about, and we could talk about maybe some of those specific scenarios in the future, but just for our general everyday 12 lead, this is what we're doing. Okay? Moving on, this is our box. We have a rectangle that is divided into different leads with 12 different squares. Each square is going to represent a geographic location of the heart. It's going to be looking at one specific portion. And so this just gives you a more comprehensive, accurate depiction about what is going on electrically in the heart in every portion of it. And so how do I know which portions are what? Well, let's go over it. So, pardon me, got some notes here. I just want to make sure I giving you correct information. All right, so starting with lead 1, that is going to cover our lateral portion of our heart. Lead 2 is going to cover the inferior portion, as is lead 3. AVR, we are not going to measure the electrical activity in AVR for general 12-lead viewing. We could go into the specifics of why in the future videos, but for general 12-lead interpretation, that's what we're talking about today. So AVR is going to be skipped over for now. AVL, lateral portion. AVF, inferior portion. V1, septal. Remember I said you have a heart separated by we have a left chamber and a right chamber that is separated by a septal wall. So this V1 here is looking at that wall, specifically the interior. V2, also septal wall. V3, anterior portion. V4, anterior portion. V5, lateral. V6, lateral. So, in theory, if I am seeing an abnormality in V5, V6, and V1, that tells me that something is wrong in the lateral portion of this patient's heart. Could also say AVL. Sorry, forgot about AVL. Likewise, if I see abnormal activity in lead 2, lead 3, or lead AVF, that tells me that on the inferior portion of the heart, something is wrong. So I want to give you guys a little analogy here. This helps me. I like analogies, and it just helps me visualize things. So I've drawn a house, and let's say that you were in the market for a house, and you get on Zillow and you see one you like, but you're not just going to go out and buy the house. You're not just going to say, click, here we go, I want it. Put in cart. Well, one, that's not how it works, but two, you wouldn't do that. You would want to go in and inspect it. You want to make sure it's as good as the pictures, that the bones of the home are stable, and that it is safe. There's, not any safety concerns. And so you're going to get an inspection on the house, and you're going to either send someone to go out, look at it, or you're going to go look at it yourself. And so that inspector is going to take pictures of this house. And so just like pictures of this house, a 12 lead is taking pictures of your heart here. So let's say I'm going to make a little dotted line here. Not very good at drawing 3D, but bear with me. All right, we'll say the square beneath is the foundation. Okay, and we are going to start taking pictures. We're going to take pictures here. We're going to take pictures along the sides. We'll probably go take pictures around the back side. We're going to want to see what's the front of this house look like. Do I need gutters that need changed? Is my front door stable? Is it a lock? Do I need siding that needs replaced? What about my windows? Also go inside and let's take a look at our the studs of the home. Are these walls stable? Are they load bearing correctly? Are they set up? Was this set up by a licensed contractor? Is this legit? You're going to want to make sure that everything in this home is good to go. And so just like this 12 lead, we are taking pictures of the inferior portion. We're taking pictures of the lateral portion, the anterior portion. Oh, I mixed up these, sorry. Anterior portion and our septal portion. And we could even posteriorly. Again, going into different setups with lead placement, there is a way to check the posterior portion of the heart electronically. Generally set up like what we just reviewed, that is not look at that, but there are ways to do that. So again, this analogy just shows that, hey, just like you would assess a home that you're going to buy and you would look at all aspects of it, you make sure the siding and the windows are good, that the doors lock and are safe, and that every portion of the home, you're not just going to look at, what does it look like from the front? No, I'm going to take a 360. I'm going to go inside and out, and I'm going to have someone look at the foundation. This 12 lead is not too unlike that. So for example, if I am seeing issues in the inferior leads, to me, that tells me that there is something going on here, and it could potentially be a blockage. That's why that's important, and that's how that all works. So when you're looking at this, again, you were looking at specific portions of the heart. Okay, so let's move on, and I want to talk about our general normal that's not how you spell that word. Okay, our normal sinus rhythm here. So what you're seeing here, I have a P wave, Q, R, S, back to the baseline, which is referred to as our isometric line, which is basically the neutral point electrically. And then I also have my T wave. And from here, we would repeat. So this would go P, Q, R, S, T, P, Q, R, S, T, down and down and down and down and down. All right. So what do these different lines mean? Well, our P wave here, use the highlighter here, our P wave is going to be the first positive deflection. That is going to be generally for our normal sinus rhythm. It's going to be a small bump that is, again, positive, so it is going to deflect up, and it's going to be round upright, and it's going to be before our QRS here, and that signifies electrical activity through our atria. So that is the depolarization of the cardiac muscles in our atria. So that is deoxygenated blood from the body getting squeezed to our right ventricle, and oxygenated blood from our lungs getting squeezed to our left ventricle. I might have gotten those. I might have gotten my right and left mixed up here. So resetting here, the P wave is measuring the electrical depolarization of our atria. So the top chambers of our heart. Okay. Now, the QRS complex is referred to as a complex because they are viewed together. It is one wave that is comprised of three smaller waves, but it indicates one specific thing, so that's why it's grouped together. The QRS complex signifies the electrical depolarization of our ventricles. Now, if you might recall, before I talked about how the left ventricle specifically, again, I might as well just label these. Okay, our left ventricle specifically has the most responsibility of the heart, so it is going to deliver blood to the entire body. And so when I say most responsibility, I just mean that it is, again, it's going to have the most demand, the most electrical stimulus is going to go through the left ventricle because it has much more required of it. It's going to require more force to effectively push blood through the entire heart. You know, what's going to take more muscular effort, to squeeze blood from the right atrium to the right ventricle, or left ventricle to the entire human body? Option B. So what I mean by all that is basically that is why this specific complex is so much larger than the other ones, because it requires more electricity. That's what you're seeing. So the QRS represents depolarization of our ventricles. T wave here. Moving on. What our T wave is representing is the repolarization of our ventricles. So that is basically the resetting of our cardiac muscle tissues so that they can then be depolarized again, meaning they can then contract again, creating this cycle over and over and over. So if you're keeping track and following along here, you might notice that we have depolarization of the atria, depolarization of the ventricle, repolarization of the ventricle. Well, what about repolarization of the atria? I mean, well, they need to repolarize so that they can then be depolarized again and contract? Yes, they do. So, and they do repolarize, but visually speaking, with our rhythm, we're not going to see that because it is lost and it takes place. Oh, sorry, use my black marker. It is going to take place in this spot, in our QRS. And so, and what I mean is like this same time frame. So when, it's supposed to be a clock, not very, I think I'm a artist over here, but so when our ventricles are depolarizing, at that same time our atria is repolarizing, but we're not visually seeing what that looks like because of how much space the QRS complex takes up. Again, it's a large, there's a large electrical demand physically for the muscle tissue, and so because of that, the P wave repolarization is, or the atria repolarization is lost in that QRS complex. So that's what you're seeing with our P wave, our QRS wave, and our T wave. And when you have these things, you have a sinus rhythm. Sinus referring to the sinoatrial, good Lord, sinoatrial node. So many terms and phrases, your mouth and brain kind of turns into marshmallows after a while. But hang in there. We're doing good. We're doing great, and we shouldn't have too much further to go here. So with the P wave here, it is round, upright, relatively small compared to our QRS and T wave. What that indicates is that is coming from our SA node. Now, we will go into this further, but just to kind of give you a little sneak peek into some of what we'll be going through. So we have our P, Q, R, S, T. All right. So this P wave here is relatively small. It's round. It's upright. Again, like we said, that SA node. But what if we had a P wave that went, oh, nope. What if we had a P wave that went like this? Well, that's upside down. It's similar. It honestly just looks like it's flipped. But that indicates that it's not coming from our SA node. That's a clue to me that this is not working correctly right now. And where it is originating is actually our number 2, our AV node. Again, the AV node has a noble effort in carrying on the work of the SA node, but it's just not as good at it, and so it's not going to be quite the same. And that is a clue to me as a provider that this cardiac rhythm is not being initiated by the SA node, and there's something wrong electrically. Now, you can still totally have a completely stable patient with this, but again, it just gives you a more accurate depiction about what's going on with their heart. And we will go into that further in the future, but just wanted to give you a little heads up on what that meant. So to tie things off here, I want to talk about these boxes. We have tons of boxes in our 12 lead, and it can be overwhelming because they are very small to look at. And as we're getting older, it's kind of hard to see small stuff. So we have these tiny little boxes that are put together to create bigger boxes that are stacked on top of each other. It's just, there's a lot going on. It's kind of busy. So what we're essentially measuring is time and electricity. So horizontally, our horizontal axis, we have seconds. Vertically, we are measuring millivolts, electricity, how much electrical demand, not demand, but how much electricity is being read through our cardiac muscle tissue via our electrodes. And so we are seeing that stimulus over a period of time. That's what we're seeing. And so we have these, again, I can only zoom in so far with these with this program, so I would just use these boxes, but they're a little too small, so I made my own here. So our tiniest box is going to be, well, wait a second here. Sorry, no. We have big boxes that are made up of small boxes. 5 big boxes together are going to be 0.2 seconds. One of these big boxes alone is 0.04 seconds. As well as up here, we have, let's see, so it would be 0.1 millivolts per 4 boxes vertically. And so, again, that's all we're looking at here. We're looking at millivolts vertically, seconds horizontally. And that's the intro to 12 leads, guys. Again, it's a really big topic, and we could go very deep into this, and we will go deeper. But this part 1, I just wanted it to be, generally speaking, for everybody out there. Oh my gosh, I knew I was forgetting something. Before we finish this, a train wreck. Bear with me, guys. I want to talk about indication. When are we doing these, and why are we doing so many of them? So let's talk about cardiogenic shock here. So going back to your EMT class, your advanced class, your paramedic class, your EMR, we learn about shock, the different types of shock. Specifically, I want to think about cardiogenic shock. What does that mean to me? Cardiogenic shock means when our heart does not have enough blood to do what it needs to do, and our patient starts to decline because of that. It's no longer effective because it does not have either enough blood supply in itself to perform, or there's some sort of physical barrier preventing that. So there could be a output issue, like the heart just can't. There's like an ejection fraction issue, or potentially they're very bradycardic. If I have a heart rate of 20, I'm probably not going to be able to supply my body adequately to have perfusing organs. So I'm going to enter cardiogenic shock. Any time where I think there could be some sort of cardiac compromise and or cardiogenic shock, I'm going to throw a 12 lead on. So what does that mean for you? Let's talk specifics, all right? So we have our non-traumatic chest pain, plus older than 25. I'm thinking syncope. Generally weak. Congestive heart failure. Shortness of breath. That is just unexplained. Why are they short of breath? Their lungs are clear. What's going on? I'm also going to talk about, I'm not going to talk about it, but I want to throw up diabetic issues as well. Specifically, are diabetics with strange atypical symptoms that don't really point towards one specific illness or injury. I'm going to think, I want to see what this heart's doing. We can talk, this list could be very exhaustive. So that's why I try to preface it with a general concept for you to apply when you're on runs. What is going on in the heart? Is it potentially not operating on all cylinders? And if so, I want to do a 12 lead. But going into the specifics, these are some of those things. Let's go hypertension, as well as bradycardia and tachycardia. Those are a general list for you to start with, but I want to challenge you to think less black and white about this. Instead of memorizing a list, I want you to apply your noggin and think, what's going on with this patient? Could I potentially get some information that might benefit this patient and their care team down the line by getting a 12 lead and transmitting? Going back to that last word, transmitting. Transmitting this 12 lead is very important, and it's something that I am rarely seeing in our, I'm starting to trail off and play with my whiteboard here. It's something I rarely see in ESO when I'm looking at charts. I see 12 leads done, but rarely am I seeing them transmitted. And so, again, I just want to urge you guys to think about what you're doing and why you're doing it. That's great that we're doing a 12 lead, and it's great if we can read the 12 lead, but we are not the doctor and we're not the cardiologist. We're not the specialty care team that is in place for this patient. After we're done with them, they're the ones who need to see this information most. And so, when we transmit that 12 lead, very often it is sent immediately to cardiologists and cath labs, and doctors start doing things right away, really. And so I'm going to urge you to just think about, if I'm doing a 12 lead, am I transmitting that? And if you need help with that, again, reach out to your crew, reach out to me. There's a lot of resources around you that can help you. So y'all, that's 12 leads, part 1. Again, thank you for your time. I appreciate it. If you have any questions, I'm here for you. Keep up the great work out there, and I will see